Welcome to Hot Topics in Kidney Health, brought to you by the National Kidney Foundation. Each episode, we highlight the latest in kidney research, bring you up-to-date news in kidney care, dispel myths, and answer your kidney health questions. Make sure to rate and review us on Apple Podcasts, Stitcher, Spotify, or wherever you listen to podcasts to help more people with kidney disease discover us. We really appreciate it. Now, on with the show. Vascular access is a lifeline for people on dialysis. Today, we'll cover the different types, how doctors determine the best option for you, what the surgery and recovery involve, and more. Hello, all, and welcome back to another Hot Topics in Kidney Health episode. I'm your host, Marlena Chesner, NKF's Digital Content Development Manager. Today, I'm joined by Dr. Vandana Dua Niyyar and kidney warrior Brittany Dickerson to discuss vascular access, an important topic that will hopefully help you all listening feel more informed and confident in your care. I'm so thankful to have both of you on today's episode. I'd love to start with some introductions. Dr. Niyyar, can you tell us a bit about yourself and your work with kidney patients?
Thank you. Thank you for inviting me. Thank you to NKF and thank you, Marlena. And nice to meet you, Brittany. I'm Vandana Dua Niyyar. I'm a nephrologist at Emory University and I've been here since 2002. And my interest is in dialysis access with the goal really to see what we can do on our end to optimize dialysis access care for our patients.
Oh, I absolutely love that. Thank you so much for being here with us today. Brittany, would you like to introduce yourself and tell us a bit about your kidney journey?
Most definitely. My name is Brittany Dickerson. I reside in South Carolina and I have polycystic kidney disease. And my disease was diagnosed at the age of 12. But despite my diagnosis at 12, I led a pretty normal childhood and adulthood. My kidney disease didn't start giving me any issues until about maybe 2018 due to my blood pressure being uncontrolled. So because of my blood pressure being uncontrolled, my kidney disease became super aggressive and I entered into kidney failure. Thus far with my journey, it's still being written. However, I have gained experience with peritoneal dialysis and currently I do in-center hemodialysis Monday, Wednesday, and Friday. And I am currently looking for a living kidney donor. And I'm also listed with about 4 transplant centers nearby. So my story is still being written, but I'm definitely glad to be here to share my experience and share information about accesses.
Absolutely. Thank you for being here. And, we definitely are wishing you all the luck in finding a transplant. I love that you're still writing that story. So I'd love to start today's discussion with some definitions. So Dr. Niyyar, what is vascular access and why does someone on dialysis need one?
I think the easiest way to understand that is to realize that when the kidneys start failing, a lot of people just think of kidneys as sort of making urine, but the kidneys really do a lot of work in the body. And one of the works that they do is they get rid of the toxins and the waste products. And the other thing is they get rid of the extra volume. So everything that you eat and drink, and if you're not able to metabolize that or if your kidneys are not working, then what you do need is some kind of way to replace the kidney function. We call that kidney replacement therapy. And it can be done in 3 major ways. One is dialysis through the blood, which is the hemodialysis. The second is dialysis through the peritoneum that Brittany referred to, and that is peritoneal dialysis. And the third one is getting kidney, whether you get a living related, living unrelated, or a cadaveric kidney. And of course, we've started hearing about the xenotransplantation as well. So there are many different ways to replace the kidney function. And for hemodialysis, the way that you replace the kidney function is we literally access the circulation to clean the blood. When we say access, we are really saying access to the circulation through a dialysis access. And this can be also of many different kinds: arteriovenous fistulae, arteriovenous grafts, and central venous catheters. And we can go into more detail later on into these. But it's just a way of getting access to the circulation so we can clean the blood. Running it through a dialysis machine is what is hemodialysis access.
think that makes a lot of sense. And yeah, as Brittany, you said that you had spent time on hemo and PD. So I'm curious what types of accesses you've had.
I have had the central venous catheter, which was basically in my chest. It can be long or it can be short, but I started out with that in center hemodialysis. And what I currently have is a graft, which is a tube that's in my arm, so to speak, that is used to access my blood. It's a loop, and that's what they use every time I go to dialysis. So I've had those two, the neck catheter, and of course I have this. And I've had previously, when I did peritoneal dialysis, I had a peritoneal catheter.
Were there any that Brittany didn't mention that you can kind of define for us a little bit more?
Yes, absolutely. So the fact that Brittany has a loop graft in the upper arm tells me she probably did not have, and Brittany, correct me if I'm wrong, the vasculature that was needed for an arteriovenous fistula.
Absolutely correct.
So I would say that when you start to think of different ways to provide hemodialysis, you are looking at hemodialysis or vascular access, which is what we're discussing today. And there are, as I mentioned earlier, three different kinds. The arteriovenous fistula is something that's native to us. So there is no foreign material when you have an arteriovenous fistula. And the way it's named is that when we say arteriovenous, it's an artery that's connected to a vein. And so when we name them, for those who are professionals, we actually name them by the name of the artery first and the name of the vein second. But for all generic purposes, it is an artery that's connected to a vein with no foreign material. An arteriovenous graft, as Brittany, you just alluded to, is a piece of plastic. Every time somebody needs to get surgery for an access, they have what's called vascular mapping. And I want to clarify that it is vascular mapping, even though the terminology that's used mostly is vein mapping, but we do both the arteries and the veins. You want to look at the artery because the artery is what provides the inflow into the access. You want to make sure it's of the right size, it flows well, there are no calcifications. And then you have the vein that we look at, and we look at certain numbers, diameters, and depth, and we also look at the flow through the vessels. And once you have the vascular mapping, as physicians, the surgeons will actually be discussing all the different options with the patients. And Brittany, I'm sure you had this conversation with your surgeon that ideally the option, especially for someone as young as you, we prefer for the majority of the patients. So it's not a one size fits all, but if you have the anatomy and the vasculature, we prefer you to have an arteriovenous fistula. But if that's not an option, then we do an arteriovenous graft. And right away, when she mentioned, Marlene, that, she had a loop graft in the upper arm, that means they use the axillary artery and the axillary vein. So one caveat that we use for deciding what surgery the patient is going to have is we start from the wrist and we move upwards. So the fact that they used the arteries that were both close to the shoulder, the artery and the vein that was close to the shoulder, suggests that everything below that was too small. And which is why an arteriovenous graft is a great option as well. There are many different kinds of materials that can be used to connect the artery and the vein if they're too small to be connected to each other. And then you have the central venous catheter, which also has its uses. The fact that we can use it right away after placement is a great point for central venous catheters. Also, it's a bridge. So, Brittany, if you were to have an arteriovenous fistula, it does take time to mature. It's not like a graft. Some of the new grafts actually can be used within 24 hours, but the older grafts would take us around 2 to 3 weeks. And so for the bridge, a central venous catheter is still a good indication. The issue is when the central venous catheter becomes the primary mode of access for a long period of time, because in the long term, it is not most optimal access for most patients, only because it has risks for infections and risks for blocking the main vessels that are going into the chest. So that's just a brief overview of the three different accesses.
Thank you. No, that was really great. And I'm curious, Brittany, what did that conversation with mapping look like for you? We now know that you had smaller veins and that's why you got that type of access. So,
Yeah.
yeah, what was that like for you?
I went to a radiology provider to get the vascular mapping done. And, as she stated, it's just an ultrasound where they, start from here on up and everything. And the mapping was easy peasy, very comfortable. After I had the mapping done, I would say within 2 weeks, I met with this vascular surgeon, and he let me know that based on everything that he got from the vascular mapping, his best suggestion would be a graft. Again, he did let me know that they try to make feasible a fistula because it lasts longer and it doesn't involve a foreign object in the body, but it just wasn't allowable for me due to my body and my size and my veins. But he did an amazing job on my access. I'm not going to dig too much and too far ahead, but I've had people tell me not so great experiences that they've had with an access, but ultimately, mine was great. It was amazing. I couldn't have asked for a better experience, especially getting this after having a catheter in my neck. I had that catheter for almost 11 months before I was able to get an access in my arm. And as she alluded to with, the access in your neck, they don't want you to have an access in your neck that long because it has so many different risks. But I was able to use my graft within 2 to 3 weeks after it was done. It was great.
The other point with the central venous catheter, right? You cannot shower with the central venous catheter.
No,
And
you
so that
cannot. It's very hard to not be able to keep up on your hygiene with that neck catheter. I've come across other kidney warriors that don't listen and they shower, but then they run into other issues with their health and infection, their catheter getting wet, things like that. So for me, I followed everything to the T because I knew just how fragile getting anything into that catheter would be because it's going directly into your bloodstream, just directly there to your heart. So I followed it to the T, and not showering for that 9 to 10 months. It was bad, but I was blessed to say that I had no issues with my venous catheter at all.
That's really good to hear. But it brings up another question. Are there other pros and cons to each of the different types of access?
Yes, definitely. So I would say you kind of want to think about an arteriovenous fistula as a late starter. If you have the anatomy, it's a great option. The issue in the United States, more than perhaps a country like Japan, is that we have a very high primary failure rate. What that means is that when the surgery is done to put the arteriovenous fistula in or to make that connection, you think it would be a relatively straightforward connection. Depending on which study you read, I would say the average is around 30 to 50% failure rate. So, what we do want to disclose to all our patients right at the beginning is that we think an arteriovenous fistula may be the best option for you, but there is 70-30 or a 50-50 chance that this surgery may not work. And that is really critically important because there have been studies that have shown that patients who've had more than 2 to 3 surgeries start having what we call surgical fatigue. So you have to be extremely careful in the first access that you put, and which is why I'm so happy to hear that Brittany had a great experience, despite the anatomy not being suitable for more peripheral accesses or a fistula. The fistula does take its time to mature. And I will say that the average time is quoted as 4 to 6 weeks, but on an average within the United States, given all our processes and everything else and multiple back and forth appointments, could be up to 3 months. And that is an underestimate. So it does take time. And during that time, if you do need dialysis, ideally this process should be started when the kidney function is declining. But if this happens in an emergency or the kidney function is declining slowly and then there's an acute event, somebody has an infection or a heart attack or something else that causes them to have an accelerated decline of their kidney function, then you need to do what you can, and people will put in an arteriovenous fistula and at the same time a bridging tunnel catheter that will give them the dialysis they need. However, once a fistula is mature, specifically the ones that are at the wrist. So what we call the radial artery at the wrist and a cephalic vein. So a radial cephalic. I've had 3 patients who've had a radiocephalic fistula for 30 plus years. And this is a bias of mine, but I honestly feel that a patient's opinion of dialysis is based on their access. So if they've had a difficult access, they find the whole process even more cumbersome because it involves inadequate dialysis, multiple trips to surgeons or proceduralists, and it does color the way they think about dialysis. I personally do think that every patient who starts dialysis should be preemptively listed for a kidney transplant. And Brittany, yay to you for being listed at 4 different centers. I always tell my patients, get listed at more than one center wherever you can go, because it's the first year that's you need regular follow-up. But after that, you can follow up with the general nephrologist in your home base. But it's important the transplant does add quality of life and time to our patients' lives. But I've seen my patients who have radiocephalic fistulas that work well, that have never required any interventions. Some of them tell me that they don't even want to consider a transplant because they find it very convenient and they've never really had any bad outcomes related to their access. But that being said, like I said, I strongly believe that everybody should be listed for a transplant. Arteriovenous grafts are sort of intermediate between fistulas and catheters, because when you think of an arteriovenous graft, the one thing is, because it's a plastic tube, it's easy to see. So it's much easier to cannulate or to put the needles in for the dialysis staff. It bypasses the need for having a certain anatomy, but because it's a piece of plastic, because it's a foreign material, the body reacts to it. The official scientific term for that is neointimal hyperplasia. But basically, all that means is that there is scarring around the area where the graft has been hooked up. And that can be a problem for patients who have grafts, that they tend to clot or to thrombose a lot more than arteriovenous fistulae, because fistulae are native and they have multiple vessels to flow through. The graft is just now, think of it like a main road or a main channel. It only has that one channel. So if that channel gets blocked at the end, then there is no other way for the blood to flow. And so that does cause thrombosis, or frequent thrombosis is a problem with grafts, but there are always signs. So somebody who knows their access well, what I tell everybody is always, we have these throwaway stethoscopes, and you can actually listen to the flow in the access. And when you hear a change, bring it up to the people who are taking care of you. But even without the patient being involved, though I really advocate for patients to be involved, it is important for our staff to be able to examine the access, to look at signs on the dialysis machine, the alarms going off. Once you take out the needles, when patients start bleeding for a longer period of time, or if their labs don't show a good enough clearance, all of these are signs that suggest that the access is starting to become dysfunctional. And if we act on it sooner rather than later, we may not have to deal with a thrombosed access. Thrombosis is clotting. The graft clots, or even the fistula can clot, depending on what the issue is. We already talked about the central venous catheters. The central venous catheters are necessary in some areas because we do need them to provide immediate dialysis. They can be tunneled or non-tunneled. So if a patient is in the hospital and they just need the dialysis either for a short period of time, or we don't have time to put in a tunnel catheter, we can use a non-tunnel catheter that can be actually placed right at the bedside. And then the tunnel catheter does require us to have special machines so we can actually see where we are going. As Brittany pointed out, the tip of both of these catheters sits in the heart. So any infection you get can spread very easily throughout the body. And then, as we talked about, it causing blockages, or what we call stenosis. I had mentioned earlier that we start from the wrist and we move up towards the chest. it's very hard to go back down. So the closer you get, so it's a sequential decision as you move up. So think about the central venous catheter being really at the chest area. If it has a blockage there, anything below that can be used for dialysis access. And so we try to avoid central venous catheters. And I know, Brittany, you showed your accesses. What I think is very critical to appreciate here is that you had your catheter on the right side of your chest and the graft was put on the left side, which is the ideal way it should be. Because once you have a catheter for so long on one side, most likely you have at least some narrowing. And when you put in an access, whether it's a fistula or a graft, and you try to put in a lot of blood, because we do need a lot of blood flow to be able to clean out the blood flow, that can cause swelling on that side. So your surgeon and your nephrologist and your team have done an amazing job of taking care of you and trying to, identify the pitfalls earlier so that you don't have a problem. So that's kudos to them.
And now a quick break, but we'll be right back after this message.
Make a difference in car, donate your car, we'll come and get it to Kitty Cars.
Tired of that old car sitting around? Donate it to National Kidney Foundation to support our mission of improving kidney care for patients across the country. It's 100% tax deductible and we'll tow it away for free. No paperwork, no stress, and no cost. Visit kidneycars.org or call 1-800-488-CARS to learn more. That's kidneycars.org or 1-800-488-CARS to learn more. Easy for you, powerful for someone else.
We'll do the work, lend a hand. Free pickup, no fuss, no fee. Give your car and help save a kidney.
Now, back to the show. And Brittany, I'd actually love to hear, we touched on infection and you mentioned that you were really good about following all of the protocols. So do you want to share with us, some ways that you keep yourself and your access safe and infection free?
Yeah, for sure. Once I knew that I was going down this kidney failure journey, I asked questions from the very beginning through every step. When I first got my central venous catheter placed, I paid attention to how the nurses, how the staff pulled the heparin out before starting me on treatment, just the different steps that they did. I paid attention, I asked questions, and I wanted to know what was the proper protocol. When I encountered maybe people who weren't aware of the proper protocol on how to maintain my access, I asked questions like, hey, I noticed that you do this a little differently. Can you explain to me? And it was either oh, I didn't know that type of moment, or either it was oh, we can do this or do that, but as long as, it's done, we're still good. You're still maintaining your access. You're still safe. I will say that the best teaching that I've got has been about my access in my arm, honestly. I've been able to meet great people within the in-center hemodialysis clinic. One of my techs even used to be a kidney failure patient. He went through kidney failure and he's a 2-time kidney transplant recipient, and he became a tech. And he educated me not only from the tech side, but from the patient side as well. Some may say that I am a little difficult in the dialysis clinic setting, but I don't call myself difficult. I'm just aware and I'm educated and I know how to advocate for myself. And when it comes to my access, or as a doctor alluded to, when I'm cannulated, when my needles are inserted, I show my tech when I go 3 times a week where I would like to be stuck. You have that right. You have that ability to advocate for yourself in any way that you choose to, being in center hemodialysis. If you notice that someone that is within the clinic just never misses, always does a great job with sticking you and cannulating you, you can ask if that person could stick you. You have so much power in how your treatment goes, and you have the ability to learn so much that it's just amazing to me. Had I not learned this, I don't think I would be able to flourish in this journey, honestly. But for me, I would say the best thing about In-center hemodialysis is the fact that I've learned so much. So even when I do encounter people that are new, they have questions or they have a lot of feelings about what they've just entered into, I'm able to help them and show them, just like someone showed me and helped me, that this isn't the end. And how you do truly feel about your access and different things like that, it makes the world of a difference. It really does. I've encountered a lot with hemodialysis. When I first knew I needed dialysis, I never wanted to do in-center hemodialysis. I was so adamant. I do not want to do it. I had such a horrible stigmatism against it. But it wasn't until I had gotten an infection and I had no choice. And I stepped into it through the lens of learning and just erasing everything that other people had told me about their experiences and how it negatively affected them. Once I let all of that go, my experience has been very different. Yes, it has challenges, but overall, I couldn't think about honestly about going back to peritoneal. I wouldn't.
I think that's such an important perspective to share because while home dialysis is a great option for some people, it is definitely not for everyone. And I love hearing the success stories. I am also curious, Brittany, about the needles. I know they're not everyone's favorite things. So, do they always hurt? And what helped you get adjusted to dealing with those?
For me, I have a little bit of a high pain tolerance, and I kind of like needles because I have tattoos. So I'm not the norm at all when it comes to people getting stuck with needles. The needles, they do look very intimidating because they are quite long. So they are very intimidating. I have not been able to accept looking at the needles being inserted. I haven't wrapped my mind around that yet. After I show them where I want my needles, I kind of turn my head. I can't look just yet because they're just so big and I'm just like, oh my gosh. But I will say that there is numbing cream. Some people can get numbing cream. That is an option. I've never used it because I just never really honestly thought to, but they do offer it. It can be given to patients to help them with the pain or the discomfort with being cannulated. But for me, it's not unbearable. To me, I think at times having the needles removed cause more discomfort than being inserted. But that's just me. But every patient that I've talked to is different. What I will say is within the setting of in-center hemodialysis, I've never heard anyone cry out in pain, honestly. The patients that are in the clinic, they are from all walks of life. Men, women, I've seen accesses that are not even in the arm. They're in the groin area and things like that. So I've never honestly heard anyone cry out in pain. I haven't.
That's really good to hear. We did an episode a while back about music therapy, listening to something helping a lot when the needles are inserted. I'm curious, Dr. Niyyar, are there any other tips or science-backed ways people can maybe work through that?
I think I would just say that cannulation is a sort of an area of interest for me. One of the things that is integral to dialysis or hemodialysis is cannulation. But a lot of work has not been done in this area. And when we think about it, it's really been see one, do one, teach one. And when we talk about criteria, when you're trying to examine an access, there is what you go by subjective criteria, where what you see is what you define it. And the objective criteria that people might have heard about, or the rule of sixes, are all based on ultrasound. And so we are teaching that the way to identify an access that's mature, that will be easy for the needle to go through and that you won't have complications is based on ultrasound, but our staff don't have ultrasounds. And so something that we've done within our program here is that we've taught ultrasound to our staff. And they use it to mark the access. And we've seen that the rate of complications has markedly gone down since we started using the ultrasound. And Brittany, I'm very curious to say, when you say that you tell them where you want to stick, because it's a graft and you want them to avoid sticking the same areas again and again, right? One of the things that happens now with a loop graft, you have a lot of room to go. You have a loop and half of it, the needles can be the red needles and the other half, the needle can be the blue needles, but there's still a lot of room to go. But some accesses are not that big, or they might be tortuous, or they might be curvy. And you need to have a little more help in putting the needles in correctly. And that's where we found ultrasound extremely useful as well. Because one point that I would really like to emphasize to everyone is the point that Brittany made, is that she tells people where to stick. So when you have a fistula, it's a native vein, so it can heal by itself. When you have a graft, it's a piece of plastic. As she said, the needles are pretty big. If you make holes with big needles in the same areas, you're going to damage the graft. And so that is what we call, in not so fancy terms, is one-sideitis. So you're just sticking the same point again and again because it's easy. Someone has already done it. 2 days ago, you see a little bit of a scab, you know right where to go, and it's easy to do that. But we have to get out of the comfort zone and really cannulate in different areas. And what we prefer, especially for a graft, is a rope ladder technique where you kind of put your fingers and you go up, 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 up the axis and then come down, down the axis. So you're not really hitting the same area once in a couple of months. And so, Brittany, I really like that. I think the key thing that came out of what you just said to me is what I've always believed in, that education is empowerment and every patient is their own best advocate. And I always tell my patients, who is there at every dialysis? It's you. So you have to be the one who has to make sure that, everything is done as much as possible. And the more you know, the less fear, because it's always fear of the unknown. And once you've gone through it, I'm in no ways, I'm not a patient, so I definitely don't want to speak to a patient's perspective or what they are going through. But it does make a very hard journey a little bit easier if you take the time to educate yourself and to empower yourself. And keep in mind that nobody is a difficult patient. Everybody who is advocating for themselves, none of us would want to be in that chair. You have to go through dialysis. We are here to make that as much better as we can and as less complicated as we can. So there's no such thing as a difficult patient. In fact, my favorite patients are the ones who tell us what they need. And there are some of my patients who will tell me, I think it's time for me to get this access looked at because I've noticed X, Y, and Z. So I think that is the best thing you can do for yourself.
I agree. That sounds amazing. And the fact that you're heading down and just focusing super close on changing and amplifying the experience of in-center hemodialysis, it makes the stigmatism or the experience that other people have had within the setting be changed, if that makes sense. Again, I never thought I would be on in-center hemodialysis, let alone be not willing to go back to peritoneal, because peritoneal for me was great as well. Peritoneal was good. I would have still been on peritoneal had I not encountered an infection. But God had other plans for me throughout this journey to see both ends, both sides of the journey. And what I will say to the patients that are out there is prioritize your access. This is your lifeline. Literally, this is your lifeline to ensuring that you live and ensuring that you are making the most out of your life. I will say too, as well, wash your access. I have seen different manners for different patients. I've seen patients come straight out from home, come straight into the clinic, get boom, hooked up. You should be washing your access when you come into the clinic before you're actually being cannulated. So I wash my access. I listen to my access every single morning before I go to treatment. I start my treatment at 4:30 a.m. at my clinic, Monday, Wednesdays, and Fridays. And before I leave out the door, I have my stethoscope. As a matter of fact, the clinic gave me a stethoscope, brand new stethoscope that was still in a box, and said, since you got your brand new access, here's a stethoscope. Listen to it. And I can tell, like she alluded, that if there's ever something different with my access, I can tell because I listen to it. I wash it. I'm very clean with it and I listen to it. You can tell when your access is giving signs of malfunction. The alarms that go off on your machine during treatment, pay attention to what those alarms are. Pay attention to what the pressures are for your arteria and your venous during treatment, because there's a certain number that they should be between. I can't definitively speak to those numbers, but I will say those are just things as a patient that you can pay attention to when it comes to your access during treatment. You can most definitely have your machine turned to you during treatment so you can see it. And you can see what your blood pressures are. You can see what your pressures are. You can see what specific alarms are going off. So you have a lot of room as a patient to be in control and to know a lot of things. But you just have to ask. You just have to know that that's there for you. You can do it.
I'm just going to build on that a little bit just in case anyone's interested. The pressures that I think that gets confused a little bit sometimes when patients are new to dialysis is the blood pressure is different from the pressure that Brittany was just referring to, which is the pressure within the access. And the easiest way to kind of understand it is to think of your access where your artery provides the inflow is the tap and your access is a hose. So if you have a block at the end of the hose, the pressure within the circuit is going to go up. And that is, so just think about, you're out in the garden and you've got an artery or a tap that's full blast, and then you pinch off one end of it. What's going to happen to the hose in the between is that's what happens to the access. And that's the alarms that go off. And if people want a number, it's 200. So typically 200, 250, depending on the needle size, because obviously the smaller the needle, then you're trying to push blood through, so you have different numbers. But if people were to remember one number, if they're looking at their machine, it's 200 millimeters per mercury, but that's the access pressure, not the blood pressure.
Perfect. Thank you for clarifying that, because I also was like, oh, blood pressure. So perfect. Well, I know that we are running out of time for today. Before we close out, do either of you have any last minute notes or anything that I haven't asked you about that you wanted to share?
The only thing that I would just say is that for my in-center hemodialysis patients, you are fierce. We are literally squeezing in hours of treatment into a small window. You're amazing. This is not something that has to define you in a negative kind of way. If you have questions, ask. Ask. And even if you want to double check what you were told, feel free to do that. Do not ever feel inadequate in any kind of way to ask a question. There is no such thing as a dumb question. In the journey that we're walking being kidney failure patients, it is a journey that evolves, and it evolves based on our path, where we are in it, and even the people that we encounter. So never ever feel inadequate or feel as though you cannot ask a question. And if you feel as though you cannot ask a question, find the person who gives you that comfort to let you ask that question.
I couldn't agree more. And I think, Brittany, you were an ideal patient, right? And you really had some time to sort of adjust to the process. And sometimes people don't get that opportunity. Sometimes people are just thrown right into the world of dialysis. I do want to say that dialysis has evolved so much since Dr. Kolf created the first, I don't know if people know, but the first dialysis machine was a laundry tub with cellophane paper on it. And it has really evolved a lot, not just in the machines, not just in the accessories, but also the way we provide it. In-center dialysis could also be in-center Monday, Wednesday, Friday, Tuesday, Thursday, Saturday, or it could be nocturnal, which is a night dialysis, or you could do dialysis at home. This is just hemodialysis that we are talking about. One thing that I would just emphasize again and again is that the more you know, the easier it gets. And find the people, find the place that actually answers all those questions. We do all our patients who start looking at dialysis, we have educational videos where we have peers, patients talking to patients, that's available on YouTube freely for everybody, where we talk about the different options, including hemodialysis, peritoneal dialysis, and kidney transplant and living on all of those modalities that really starts off the conversation for our patients. Because once you have some fundamental knowledge, then you can ask more informed questions when you see the doctor, because everybody's time is limited and people are rushing. It's good to have a good background, good to keep yourself aware of everything, but also understand that throughout a process, Brittany, I think you are the ideal person to showcase that you will go through all the different modalities. And hopefully, we are rooting for your transplant so that you can say, I've had hemodialysis, peritoneal dialysis, and a kidney transplant. Life changed, your needs change, and we are here to help you walk through that, but just ask.
It was such a pleasure to have you both on today. Thank you for this great information. And for everyone looking for those videos or more information, check those show notes. And until next time, we wish you all good health.
Thank you for listening. Do you have any questions? Email us directly with your comments and suggestions at nkfpodcasts@kidney.org. We hope you will join us next time. And from all of us at NKF, we wish you good health.